Hi, my name is Ailie Ross. I'm an HDR candidate here at JCU and I'll be completing my PhD on a project which is diagnosing hematological malignancies in resource poor settings and assessing ways to increase the accuracy of this approach. My background is in diagnostic pathology, where I worked for 23 years. A good number of those years I spent as a senior scientist specialising in diagnosis of haematological malignancies, and I'm also a fellow of the Australian Institute of Medical and Clinical Sciences in the area of haematology. When we take a look at worldwide cancer distribution, we can see that it's not equally distributed across the globe. This image here that we've taken from the World Health Organization on the distribution of malignant neoplasms in 2021 shows that there is quite a significant variation. The light blue shows where there are low numbers of cancer and the dark blue where there are high numbers of cancer. So while you might expect the cancer rate to be a little bit higher in high income countries, when we look at the actual distribution based on the HDI or Human Development Index, we can see that in the very high to high HDI countries, nearly 17 million of the 20 million cancer cases are situated here, and the low to medium Human Development Index countries only have around 3 million cancer cases globally. When you consider that low to medium HDI countries actually comprise 75% of the world's population, this is a fairly shocking statistic. And when you look at the low HDI countries in isolation, they have less than 5% of the global cancer cases distributed in these countries. Map, I've taken the liberty of outlining the countries that are low to middle income, and you can see that they line up spectacularly well with the countries that have a very low cancer rate. Now, to me, this seems quite unlikely. There must be something else going on here that is contributing to the very low cancer rate that we see in these countries. Now, when we actually look at haematological malignancies specifically, across the world, they actually make up 6.5% of global cancer distribution, which is a reasonably high percentage. That's around 1.3 million cases worldwide. But you can see that the incidence rate is quite different from normal distribution across the world and in first world countries. So in countries like the US, for example, the percentage incidence of hematological malignancies, which includes cancers like leukemia, lymphoma, and multiple myeloma, these also are a lot higher. So if we use the first world statistic of 9.4% and apply it to global cancer numbers, what we can see is that hematological malignancies could potentially be as high as 1.9 million cases of the 20 million global cancer cases that we saw in 2022. What this means is if there is an underdiagnosis problem in the low and middle income countries, then the shortfall could be up to 600,000 hematological malignancy cases globally that are going underdiagnosed and unreported. So what is the cause of this discrepancy? Now, the Global Cancer Report from 2020 actually stipulates that they believe that the low and middle income countries are what they call transitioning countries because they are moving to a more westernised, industrialised society, and in that regard, they're having a higher exposure to cancer-causing agents such as smoking, unhealthy diet, excess body weight, and physical inactivity. They actually predict that the rate of cancer growth in these low and middle income countries is going to increase significantly and become a global health crisis. Now, it's not expressly indicated that the low cancer incidences in these countries is due to a lack of diagnostic technologies, but I think that that is actually quite apparent and not a difficult connection to make. There are a few papers that have outlined this, and they have said that underdiagnosis and underreporting of hematological malignancies is a significant issue in low and middle income countries. When we talk about hematological malignancies, what exactly are we talking about? Because hematological malignancies include leukemias, lymphomas, and multiple myelomas, they actually comprise a fairly significant proportion of global cancers can be up to 10%, and the complexity of diagnosing hematological malignancies can actually be quite significant. So here we have a basic diagram of human hematopoiesis, where you can see it starts from a multi-potential hematopoietic stem cell, and from here it can give rise to myeloid and lymphoid cells, and then the different subclassifications there. Now, the reason I've included this diagram is, even though it's a simplified diagram, when you diagnose a hematological malignancy, it can be a malignant clone arising from anywhere in this maturation series, and dependent on the maturation of the malignant clone is how we diagnose and treat hematological malignancies. So anything that's in the more mature area tends to be a lymphoma, and the more immature cells give rise to the acute leukemias. How is a hematological malignancy diagnosed? So our mainstay of diagnosis is microscopy, and you'll find that this is fairly heavily relied upon in areas where resources are limited, because all you need is a few basic laboratory facilities and some basic knowledge of hematological malignancies and how to diagnose them. It's difficult to get an accuracy from the published data on this because it depends on what you're comparing the technology to, but it's generally accepted that microscopy has an accuracy rate of 70 to 80%. And what technologies we can use to give us the highest level of accuracy are things like molecular analysis. So this is probably the highest level of technology we can use for classification of hematological malignancies, predominantly in first world countries, and it can bring us to an accuracy rate of over 99%. It also allows us to treat with very specific drug targets, as they're often against a particular molecular rearrangement in the malignant clone. So how can we improve this accuracy rate from 70 to 80% that we're seeing in the resource limited settings closer to what we're seeing in first world countries? So there is a technology there in the middle which is called flow cytometry, and this is an area where I have spent a lot of my diagnostic time in pathology before moving over to James Cook University, and there is a high degree of variability in the accuracy of flow cytometry. So it can improve your morphological diagnosis somewhat, up to 98% accuracy, but not always to a level that is that high. So when we run our blood and bone marrow samples through a flow cytometer, we can interrogate the cell surface markers using lasers and fluorochromes, and we can more accurately diagnose these leukemias based on the maturation of the malignant cell clone. So for instance, here we have a scatter plot of an acute lymphoblastic leukemia where the cells are positive for CD19. Now this is an area where we can actually maybe make some improvements in accuracy if we can use some clever flow cytometry data. One of the first things we need to determine is what is the actual gap in diagnostic capability. So in order to determine that, we do a systematic literature review as part of a PhD. My systematic literature review focused on specifically the use of a limited panel of flow cytometry and if there are any consensus guidelines that can be used in resource limited settings. I found from looking at the papers I looked at that a narrative literature review might also be required to look at the issues of underreporting, underdiagnosis and misdiagnosis in resource limited settings, as these things are not well described in the literature. From those two things, it has become apparent that we would likely need to do a survey in resource limited settings of laboratory staff such as scientists and clinicians to find out what technologies are actually being used to diagnose hematological malignancies and what access patients have to these technologies. Once we establish the gap, then we need to work out how we can bridge the gap in these countries. So it's probably unrealistic to think that they can get to the 99% accuracy that we see in first world countries, but we can certainly improve from the 70 to 80% accuracy that we are currently seeing in these countries. One of the ways we can do that is by doing simplified flow cytometry. So as I said, there's a use of limited panels. However, this is not well described in the literature, and I'll go through that with you a little later. Simplified flow cytometry will be cheaper, easier, and temperature stable. These three things are significant hurdles for implementing flow cytometry where resources are limited. Where flow cytometry can't be performed, we will look at the use of some novel tests in these areas. So this can comprise of either novel use of existing tests, such as performing basic immunohistochemistry on bone marrow aspirates and blood films. This is a technology that is proven but is not routinely used, and also to develop completely new novel diagnostics that may be used, such as lateral flow assays or proximity ligation assays. When I conducted my systematic literature review, my initial review of the literature returned very few results when I just used key terms such as hematological malignancies, flow cytometry and diagnosis, and combined them in an AND operator in Medline. I only returned 2 papers. So I had to significantly broaden my search terms to include all the different terminology that's used for those 3 criteria that I was looking for. When that was completed, I actually returned over 1,000 papers. Now, a lot of these papers actually had a treatment focus because it was hard to exclude them just by using keywords. So we had to go through and exclude them based on the title of the paper. Once we retrieved actual reports of 140, then we could do a full literature review and scan the full text article for articles that were deemed to be relevant to the topic that we were looking for. Once that was concluded, we found a total of only 41 studies that were suitable for this review, and it was a range of studies. Within that 41 studies, we found 27 studies that included minimal panels or use of flow cytometry, and 21 of those 27 studies were cross-sectional or cohort studies involving a cohort of patients. Also included were 10 guidelines. So we have some normal guidelines that are used in flow cytometry for diagnosis of hematological malignancies, such as the World Health Organization guidelines and the Euroflow guidelines. But we also found 3 resource stratified guidelines that were not an international consensus, but did outline the use of limited panels to restrict the cost and complexity of running flow cytometry in resource limited areas. And there were also 4 studies on completely novel tests that were found. One was regarding machine learning in chronic lymphocytic leukemia patients. Another was using the preponderance of smear cells to assess the prognostic utility for CLL. One was a unique antibody for acute promyelocytic leukemia, and another explained a cell block buffer coat technique used on bone marrows to do immunohistochemistry, and this may be something that we explore in. Here's an overview of the papers that we found. I only took papers from 2009 onward, as the technology of flow cytometry was considered to be not quite developed enough prior to that time. I'll just go over a couple of themes that I found in my literature review. So looking at specifically minimum screening panels for flow cytometry, there was a paper by Gupta et al. Which actually compared a number of different methods. So you can see in their particular paper, morphology alone had a diagnostic accuracy of 75.6, but when you include cytochemistry in there, which is also available in a lot of resource limited settings, you can get the accuracy to be as high as 93.9%. There is an Indian consensus minimal screening panel that is described in the literature, and that had an accuracy of 92.7%, and they proposed a new minimum screening panel in Gupta et al. That included cytoplasmic markers that improved that accuracy by another 3%. Now it's interesting to see how they went about assessing the diagnostic accuracy of these tests, and what became apparent is there is a high degree of inter-operator variability and selection of a gold standard to compare the test to, and also what categories of acute leukemia are we actually stratifying these diseases into. Another paper that looked at the theme of minimum screening panels was a paper by Singh et al., and they looked at the accuracy and cost effectiveness of these panels. It was the only paper I found that actually compared a number of limited immunophenotyping panel and reported the accuracy or yield in percentage. And you can see as you include more antibodies in your panel, you get a higher accuracy, but the aim would be to find a minimum panel that gives the highest compromise, number of antibodies and accuracy available. When we look at the availability of flow cytometry in resource limited settings, it was very difficult to find data. I found one paper which was a survey of physicians in Ethiopia, which showed that 68% of physicians did not have any availability of flow cytometry to them. Sometimes flow cytometry was available to 19% of physicians, and it was only available always in 4%. A lot of data was missing, and it also did not quantify how many of the patients that are seen by the physicians actually had access to this technology. So this is an area where there is a significant gap in the literature. The theme of underdiagnosis was very difficult to gather information on. I found only a single paper that directly referenced the underdiagnosis of acute leukemias in resource-limited settings, and this was quite an interesting paper where they projected the expected cases versus the observed cases in Western Kenya. So even though this was focused on pediatric cancer, the majority of pediatric cancers are actually hematological malignancies. So in this particular study, they actually surveyed 31,000 malaria slides and found of those slides, 41 were hematological malignancies that had gone completely undiagnosed. So these were corroborated by taking material from the slides and getting genetic evidence of leukemia. A problem in these resource-limited countries can be that patients with hematological malignancies often present with similar symptoms to the communicable diseases, so this is an area where it's quite likely that diagnosis is being overlooked. From the systematic literature review that I conducted, I tried to get some quantifiable data so that we could make some concrete conclusions. So when focusing on the limited immunophenotyping flow cytometry panels, I looked at studies that had limited or minimum panels, which I took to be less than 20 CD markers described. And what I found was there were 12 studies that outlined this and 3 guidelines that had resource stratified flow cytometry panel recommendations with limited CD markers. The mean and the median number of CD markers per tube for these limited panels was 10. So when you compare this to the type of screening that we're doing in first world countries, you would routinely be using in excess of 32 antibodies per tube. So you can see how this would give a significant cost advantage. And then I sorted these guidelines and studies into the actual markers recommended and ranked them. So when we had a look at coming up with a consensus 10 marker panel, as that was the median number of markers, what we found is that CD19 was recommended in all panels at 100%. The next most common was cytoplasmic CD3 with the majority of panels, and this is used to determine T cell lineage. CD34 and CD10 were in 83% of the markers, and that was for stem cells and acute lymphoblastic leukemia. So when we looked through all the panels, we could come up with a consensus panel put together that would be a 10 marker panel including CD19, cytoplasmic CD3, CD34, CD10, cytoplasmic MPO, CD45, cytoplasmic CD79A, CD13, CD7 and HLA-DR. Now this is not necessarily the limited panel that I would look at using in my study, but it is a very good starting point. When a meta-analysis was performed, that was found to be quite difficult because only 4 papers were found that actually gave sensitivity and specificity data on the diagnosis of acute myeloid leukemia and acute lymphoblastic leukemia. When these were compared, it was found that the average sensitivity and specificity for both disease states was actually 92%. So the accuracy could be deemed to be 92, but there were significant limitations to these papers. The project aims I've taken from looking at the gaps in the literature and the ways to address these gaps. So my first aim would be to undertake a systematic literature review, which has now been conducted. Second aim would be to undertake a narrative literature review to look at underreporting, misdiagnosis and underdiagnosis of haematological malignancies. The third step would be to devise and explore a panel of simplified, cost-effective diagnostic markers using flow cytometry, and we're going to compare these to samples from patients that are presenting to the oncology clinic at the Townsville University Hospital. This is a study that hasn't been done previously, and I think it would go a long way towards filling a little bit of that gap that we can see from the literature review. The fourth step would be to devise and explore a panel of simplified, cost-effective immunohistochemistry markers. On to developing some novel tests. Once we have a library of samples that we can test these things on, then we can assess the diagnostic accuracy and precision of these tests compared to gold standard testing, and then we can assess them for the utility in a resource limited setting such as ease of use and cost of test. After that, we could explore the limitations to implementation of these simplified diagnostic protocols through a staff survey to evaluate staff training needs, consumer availability, sustainability and costs associated with testing, both in Townsville and in resource limited settings such as Fiji and PNG. Ideally, these would be places that we could implement these technologies because we have already close associations through James Cook University with both of these settings. They are resource limited settings and have unique sets of challenges for both. Once we have conducted that staff survey, we will be better positioned to see how we could develop an implementation plan to use these simplified diagnostic protocols in a resource limited setting and then assess the outcomes of this. There are some potential limitations from this study. The most significant hurdle would be ethics approval. We are aiming to get patient consent. However, this is a greater than low risk study, so we'll need to go to a full ethics meeting for approval at the Townsville University Hospital. If this does not pass, which is unlikely, then we could potentially use discarded pathology samples to test our protocols. The second limitation may be the rate of sample collection, so we may need to extend our sample collection period if the number of malignancies that present to the oncology unit are lower than is anticipated. This should not be a significant issue as the technologies that we're employing are heat stable over a significant period of time, so we won't have any disadvantages from extending that rate of sample collection. The third limitation may be the degree of grant success. So we have applied for a number of grants with varying likelihoods of success. We have applied to AIMS for a research seeding grant of $10,000, which is quite likely to be successful. And from there, we can complete the majority of the elements of the project. We've also applied for a CERTA grant, which has a lower chance of success, but that will be the grant that allows us to develop novel tests if we have the ability and we can test them to give the project a little bit more complexity. We can mitigate this by applying for additional grants as well and changing the research protocol to reflect the resources that we have available. And the last limitation would be collecting unexpected results. Because of the technical expertise of the supervisory team and myself as well, we feel that this is very unlikely due to a high level of industry experience solving technical issues. We have multiple modalities, so this should allow for a statistical analysis in the event of a failure of one of the more unpredictable or novel tests. At the completion of this project, what are the outcomes that we would like? Because we are defining a number of different test protocols for limited resources, we are hopeful that at least one will show something that provides improved accuracy and is also logistically feasible for a low resource setting, in that it is cost effective, heat stable, and a simplified protocol that requires minimal training. We would like to develop a pilot study in a resource limited area such as Fiji and PNG to trial the novel test protocol and then compare the outcomes and assess these for improved access to treatment, better prognostic information for patients, enhanced accuracy in diagnosis of haematological malignancies, and quality of healthcare data to better inform health policies in low and middle income countries. project has shown that there is a significant gap in the literature that we can address. In Townsville, we are uniquely positioned to be able to look at this particular issue by comparing a protocol for a resource limited setting in a first world country with first world protocols as the gold standard. So I think this will be a really interesting project which will have some quite unique outcomes, and thank you very much for listening to my presentation today.